Hello, dear friends and doctors. I'm going to talk a bit about Mrcp basis consultation station, and today we're going to discuss scenario of patient with bronchiectasis. So let's move on. Here is our case scenario. Mr. Johnson, 45-year-old man, presents to the clinic with a chronic cough and recurrent chest infection for the past few years. He complains of daily sputum production, occasionally greenish in color. So in the consultation station, this is the new station, and we have 20 minutes in this. And the first 15 minutes is for you to take the relevant history, do the examination, answer any patient queries, and the 5 minutes is for the examiner to ask you some questions regarding the case. So how are we going to approach this case? Once we read the scenario, then we're going to brainstorm. And in this case, it's quite obvious that we're dealing with some respiratory case, and we must be thinking about differential diagnosis, like maybe it could be COPD, bronchiectasis, pneumonia, or maybe bronchial asthma with acute exacerbation. Or so all the differential diagnosis related to the respiratory system, you must think about it. So once you enter the room, you're going to greet the examiner and greet the patient, and then you're going to take the consent and start with your history. So in this history, presenting complaints first. So chronic cough with daily expectoration of occasionally greenish sputum, recurrent chest infection for several years, and increasing shortness of breath, especially with physical activity, nocturnal coughing spells disrupting the sleep, denies chest pain, hemoptysis, or unintentional weight loss. So these are the important questions which you should ask. An important thing in this, the catch here is recurrent chest infections for several years. And once the patient gives this history, then you must be thinking about some chronic cases, chronic diseases. Then we're going to talk about the past medical history. So this is also very relevant in this case. Childhood history of frequent respiratory infection and pneumonia, previously diagnosed with asthma during teenage years, feel current symptoms differ from previous asthma attacks. So childhood history of frequent respiratory infections and pneumonia. This is another buzzword. Family history, mother has a history of recurrent respiratory infections and bronchiectasis, suggesting a possible genetic predisposition. We're going to talk about a social history. Patient is a non-smoker, no significant occupational exposure, married, works as an office manager, lives with wife and 2 children, no recent travel to areas with endemic respiratory diseases. Here we're talking about the tuberculosis, no allergies or exposure to environmental pollutants at home or work. And functional status, experience shortness of breath, especially during physical activities, no limitation in daily activities despite the symptoms. So I put a model history here, but remember, always follow the format. So first we're going to start with the presenting complaint, past medical history, family history, social history. In this patient with a difficult shortness of breath, occupational history is very important, and going to talk a bit about the functional status of the patient. So moving on, after you've done the history taking, you're going to take the consent and proceed with the examination of the patient. So in the general appearance, Mr. Johnson appears cachectic, so indicating some state of malnutrition and wasting, and appears fatigue, which obviously suggests any chronic illness. So respiratory examination, we're going to do the inspection. Mr. Johnson exhibits labored breathing at rest. There is visible use of accessory muscles of respiration, pursed lip breathing, which is seen in chronic respiratory conditions. So on the inspection, you should look for all these signs, so to get an idea about the diagnosis. Then we're going to do the palpation, bilateral expansion of the chest, and we expect the bilateral expansion of the chest to be decreased, indicating reduced air entry into the lungs. Tactile vocal firmness increased over affected areas, maybe suggests of consolidation or bronchial obstruction. Percussion, then dullness over areas of consolidation or pleural effusion, if present, and hyperresonance over areas of lung hyperinflation. And then we proceed with the auscultation and expect to find coarse crackles and V's heard bilaterally, so indicating airway secretions and narrowing respectively. Prolonged expiration, which is characteristic of obstructive airway disease, and absence of breath sounds in areas of bronchial obstruction. So once you've done your respiratory examination, you're going to proceed with the cardiovascular examination as well, because shortness of breath can appear in the cause could be related to some cardiac problem as well. So going to do some inspection, no visible pulsations or heaves on precardium, palpation, normal apex beat location and character, look for the apex beat, and auscultation, regular rate and rhythm of heart sounds, and no murmur, rubs or gallops detected. Going to do the abdominal examination as well, inspection, no scars, liver edge may be palpable. Sometimes it can be palpable in cases of chronic diseases. No tenderness or masses on palpation, and then you're going to proceed and check the extremities as well, especially the upper limbs. Look for any possible signs of clubbing, any cyanosis or edema, and the lower limb any peripheral edema or any signs of deep vein thrombosis. So this is how you're going to proceed with the examination. Remember, this is a consultation station, so do all the examination starting with the respiratory, cardiovascular, abdominal, and examination of the limbs. So what could be the differential diagnosis in this case? Bronchiectasis on the top of the list, chronic cough, daily sputum production, coarse crackles, wheeze, and digital clubbing observed in Mr. Johnson. So bronchiectasis is the most likely diagnosis given the symptoms and signs, and we know that it involves the permanent dilation and destruction of bronchial walls, leading to chronic cough, sputum production, and some recurrent respiratory infections. Another important differential diagnosis to consider is chronic obstructive pulmonary disease. The patient has chronic cough, he has wheeze, tachycardia. It can be seen in COPD as well. It is characterized by airflow limitation and is often caused by smoking. So Mr. Johnson doesn't have a smoking history mentioned, but still a consideration given his symptoms. What another differential diagnosis we can consider is asthma. Wheeze, shortness of breath, and coughing, especially at night, these are common in asthma, and we all know that asthma is a chronic inflammatory condition of the airways and can cause airflow obstruction. So Mr. Johnson's symptoms might resemble asthma, and the chronic nature of his condition, however, and the absence of significant improvement with bronchodilators make it less likely. So asthma normally is since childhood, and there are, relapsing and remitting phases in the asthma. While in bronchiectasis, it will be something we call it progressive disease. Interstitial lung disease, we're going to think about this differential diagnosis as well. Progressive dyspnea, dry cough, and crackles on auscultation. So interstitial lung disease actually involves scarring of lung tissues, leading to impaired gas exchange. It can present with crackles. Other findings like restrictive pattern on pulmonary function tests are typically seen. Cystic fibrosis, very important differential to consider. Cystic fibrosis patients do have chronic cough, they have recurrent lung infections, digital clubbing, and failure to thrive. It's a genetic disorder, and it causes thick, sticky mucus production and leading to respiratory symptoms. So although Mr. Johnson's symptoms, they align with cystic fibrosis, the absence of symptoms during childhood and failure to thrive make it less likely. So that's why the past history is very important. Primary ciliary dyskinesia, another differential to consider. Chronic respiratory symptoms, recurrent infection, and situs inversus. So it's a genetic disorder affecting cilia function, leading to impaired mucociliary clearance. Situs inversus, a reversal of the normal position of organs can be associated with this condition. Tuberculosis, chronic cough, weight loss, night sweat, hemoptysis. It's a bacterial infection that primarily affects the lungs. Mr. Johnson has chronic respiratory symptom, but absence of weight loss, night sweats, and hemoptysis make tuberculosis less likely, and there is no travel history as well. So these are all our differential diagnoses which you keep in mind while examining the patient with cough, sputum, and breathlessness. So what are the investigations which are important? We want to do the pulmonary function test to assess the lung function, airflow limitation, lung volume. So typically we may have a mixed pattern with obstructive district component may be observed, but remember that bronchiectasis we expect to see the obstructive pattern. High resolution CT scan of the chest. This to visualize the airways and lung parenchyma in detail. So in bronchiectasis, we may have irregular dilated bronchi and thickened bronchial walls. These are the characteristic feature. Sputum culture and sensitivity to identify bacterial pathogens and determine the antibiotic sensitivity. So there is a persistent colonization by pathogenic bacteria like Pseudomonas aeruginosa or Haemophilus influenzae. It's quite common in bronchiectasis. We'll be interested in doing the complete blood count with differential to assess for signs of infection or inflammation, and in bronchiectasis may be elevated white blood cell count indicating infection or inflammation. Serum immunoglobulin levels to assess the immune system function. In bronchiectasis, immunoglobulin deficiencies might predispose individuals to recurrent infection. Alpha-1 antitrypsin level, if it is relevant, if we want to rule out alpha-1 antitrypsin deficiency, low alpha antitrypsin level can indicate a deficiency which may contribute to lung pathology. Remember, the alpha-1 antitrypsin deficiency is also one of the causes of the bronchiectasis. Bronchoscopy with bronchoalveolar lavage to obtain sample from the lower respiratory tract for culture and cytological examination. So presence of pulmonary secretion and positive cultures for pathogenic bacteria, and genetic testing to identify possible genetic factors contributing to bronchiectasis. Mutations in genes related to immune system or mucociliary clearance might be detected. So these are all relevant investigations which you should keep in mind. Again, depending on the cause, how is the history leading to, whether the history is leading to some disease like primary ciliary dyskinesia, or we will thinking about alpha-1 antitrypsin deficiency level. So just modify it. But these are all the investigations which are important in this case. So how are you going to present this case? First of all, we're going to start with the history. So we can say that Mr. Johnson has been experiencing a chronic cough with daily expectoration of green sputum. He has a history of recurrent chest infections since childhood, often complicated by pneumonia. His symptoms have progressively worsened, leading to increased shortness of breath, especially during physical activities and nocturnal coughing spell. His mother had a similar history of recurrent respiratory infection and bronchiectasis. And then we're going to move with to the physical examination. So upon examination, Mr. Johnson appeared cachectic and fatigued. Coarse crackles and wheeze were heard bilaterally, more pronounced in the lower lung fields. Notably, digital clubbing was observed. Cardiovascular and abdominal examinations were unremarkable except for hepatomegaly. And then we're going to suggest some investigations like pulmonary function test to assess the lung function, airflow limitation, and lung volume. High resolution CT scan to visualize the airway and lung parenchyma in detail, confirming bronchiectasis, sputum culture and sensitivity, to identify the bacterial pathogens and determine the antibiotic sensitivity, complete blood count with differential alpha-1 antitrypsin level, and genetic testing if applicable. So then you're not going to stop here, and you're going to propose the management. So proposed management in bronchiectasis, airway clearance techniques. So we teach Mr. Johnson effective airway clearance methods to promote the secretion clearance. Bronchodilators, prescribe bronchodilators to alleviate the airway constriction and improve the breathing. Antibiotics, initiate the targeted antibiotic therapy based on sputum culture results to address the identified pathogens like Pseudomonas aeruginosa. Regular follow-up, schedule the regular follow-up appointment to monitor symptoms, assess treatment effectiveness, and make necessary adjustment. Vaccination important, prevent including influenza and pneumococcal vaccine, and patient education. So provide education on symptom management, infection prevention, and the importance of adherence to treatment plan. And then you're going to conclude. In summary, Mr. Johnson presentation is consistent with bronchiectasis, supported by his history, clinical findings, and relevant investigations. The proposed management plan includes airway clearance techniques, bronchodilators, targeted antibiotic therapy, regular follow-up, vaccination, and patient education. try to memorize these themes and so that when you go on the examination, your presentation is fluent and structured. So this is how we're going to conclude. Some of the questions which the examiner may ask: can you explain the pathophysiology of bronchiectasis? So one of the answer is bronchiectasis is a chronic respiratory condition. It's characterized by irreversible dilation and destruction of bronchi and bronchioles. This results from recurrent inflammation and infection leading to weakening of the bronchial walls. Impaired clearance of mucus and secretions allows for bacterial colonization, perpetuating the cycle of inflammation. Chronic airway inflammation and persistent infection causes structural damage leading to the characteristic bronchial dilation seen in bronchiectasis. How would you differentiate between bronchiectasis from other COPD or asthma? Very common questions. So bronchiectasis can share some symptoms with COPD and asthma like chronic cough and shortness of breath. However, specific features differentiate bronchiectasis like chronic cough and sputum production, prominent and daily in bronchiectasis, and these symptoms are variable in COPD and asthma. Another differential is clubbing, often present in bronchiectasis. It can be present, but it's quite rare in COPD and very rare in asthma. Wheeze and crackles are common in bronchiectasis due to airway secretions, less prominent in stable COPD and asthma. And response to bronchodilators, it is limited in bronchiectasis, significant in asthma. Progressive structural changes seen in HRCT in bronchiectasis. So not a feature of stable COPD or asthma. Examiner may ask why it is important to identify the causative organisms in bronchiectasis and how does it influence management. So identifying causative organisms in bronchiectasis is crucial for tailored antibiotic therapy. Normally we see Pseudomonas aeruginosa and Haemophilus influenzae. These are the common pathogens, and understanding the specific pathogen helps in choosing appropriate antibiotics and considering the antibiotic resistance pattern. So optimizing treatment efficacy and preventing exacerbations and improving the patient's quality of life. Can you elaborate on the genetic aspect of bronchiectasis and how would you approach genetic testing in this case? So bronchiectasis can have genetic components, especially in case of early onset or familial bronchiectasis. Genetic mutations affect ciliary function, mucociliary clearance, or the immune system can contribute. So in this case, given the family history and the possibility of genetic predisposition, I would consider genetic testing to identify specific mutations associated with bronchiectasis. And this information can guide management and help in genetic counseling for the patient and his family members. How would you educate Mr. Johnson about his condition and involve him in the management plan? So one of the answer, I would approach patient education in a holistic and empathetic manner. I would explain bronchiectasis, its chronic nature, and the importance of adherence to treatment. I would teach Mr. Johnson airway clearance techniques and provide educational materials. Additionally, I will involve him in decision making, discussing treatment options, addressing his concern, and ensuring he understands the long-term implication of the condition. Regular follow-up appointments would allow to assess his progress, modify the management plan if needed, and provide ongoing support. So what complications can arise from bronchiectasis and how would you monitor for them in Mr. Johnson case? So complications of bronchiectasis include recurrent respiratory infections, hemoptysis, respiratory failure, and exacerbation. To monitor for these, I will conduct regular clinical assessment including lung function tests, chest imaging, and track the frequency and severity of exacerbations. Close monitoring allows early detection of complications, guide prompt intervention, and preventing the disease progression. How will you monitor the effectiveness of the prescribed antibiotic therapy in Mr. Johnson? So monitoring the effectiveness of antibiotic therapy in bronchiectasis involves clinical assessment of symptoms, including cough, sputum production, and overall well-being, periodic follow-up appointments, review of sputum culture and sensitivity reports, and assessing the inflammatory markers like CRP. And these can help evaluate the response to treatment. Improvement in symptoms, reduction in exacerbation frequency, and maintenance of lung functions. These are indicators of effective antibiotic therapy. So what lifestyle modification would you recommend Mr. Johnson to manage his condition better? So I'd advise Mr. Johnson to quit smoking if applicable, Quitting smoking is paramount to prevent further lung damage. Regular exercise, encourage the regular exercise, moderate exercise to maintain overall health and improve lung function. Healthy diet, recommend a balanced diet rich in fruits, vegetables, and lean proteins to support overall well-being. Maintain good hydration to keep mucus thin and easy to clear. Avoid the respiratory irritants. Stay clear of smoke, strong odors, and pollutants to prevent exacerbations. Flu and pneumococcal vaccination. So ensure up-to-date vaccination to prevent respiratory infections. How would you address Mr. Johnson's concern about the impact of bronchiectasis on his daily life and work? So, one of the answers is this: I would empathetically acknowledge Mr. Johnson's concern and discuss the importance of adherence to the management plan. I would reassure him that with proper treatment and lifestyle modification, he can lead a fulfilling life. Addressing any specific concern he has about work, such as sick leave or workplace accommodation, would be important, and I would involve in decision-making process, ensuring he feels empowered and supported throughout his journey with bronchiectasis. And finally, can you explain the potential role of physiotherapy in managing bronchiectasis, and when would you refer Mr. Johnson to a physiotherapist? So, here's the model answer. Physiotherapy plays a crucial role in bronchiectasis management. Physiotherapists can teach Mr. Johnson airway clearance techniques, breathing exercises, and techniques to mobilize mucus effectively. I would refer him to a physiotherapist immediately after diagnosis. Regular sessions with a physiotherapist can significantly enhance his ability to manage his condition, improve lung function, and prevent complications. So, my dear doctors, I put almost all the questions which could be asked in this case. Just modify, I've just put the model answers, just modify it according to your preference, according to your knowledge, and hopefully my presentation will help you in preparation for your MRCP PACES examination. Thank you very much, and I'll see you in my next presentation.